the neonatal seizures. So, over to you, sir.
Thank you, Sakshi, for that kind introduction. And so, with the last talk, I would not take much of your time, especially on Sunday evening when majority of you have your own plans. So, the topic I would be speaking on is neonatal seizures. In fact, seizures is one of the commonest neurological manifestation which we see in both NICU as well as PICU. So the problem with the neonatal seizures is that they are often either underdiagnosed or overdiagnosed, and in both ways it is a problem. If we underdiagnose it and continue to see them, then the child is going to suffer because seizures. This was a child who came to the OPD and he was already on multiple anti-epileptics, and he was started on this anti-epileptics and he had gone through majority of the pediatricians and he had not responded to them according to the parents. So many times whenever we see any abnormal movement, we are always in a hurry to start this or such babies on anti-epileptics, just like we are always eager to make a diagnosis of sepsis in any sick baby and start them on antibiotics. But in both cases, we should have some restraint and fully examine, take a detailed history, and then evaluate with at least an EEG before we jump on to start antiepileptics. In this case, it was a benign normal condition, which we all know is a benign myoclonus, and we stopped all the antiepileptics. Assure the parents that child's development is normal and these are not seizures, but something quite common and a normal phenomena. Similarly, uh, this was another baby who had a constant arching. He had a long NICU stay, and again, many other sisters and doctors were at least thinking that we should consider anti-epileptics in this baby because his tone looks abnormal and he's showing this arching. But again, this is not a seizure. This was again because of a common phenomena, GERD, and this is Sandifer syndrome. And this baby did well with anti-reflux measures and did not require anti-epileptics. So why is it important to recognize a seizure? It is because seizure tells us that there is some underlying abnormality which we need to correct. And if not corrected in time, it can both lead to increased mortality as well as morbidity. Similarly, do if we label any baby with a normal phenomena or a normal movement as seizures, he's going to be on anti-seizure medications, which in itself are not safe and have their own side effects. So we should always think before starting babies on anti-epileptics. Other important thing is, apart from the underlying phenomena which causes seizures, seizure in themselves can cause brain injury because of the release of various cytokines, excitotoxic substances or hormones in the brain. They can lead to hyperventilation, hypoxia, hypercapnia, aspiration syndromes, and even death. So we need to find out what is the cause of the seizures, treat seizures if they are actually seizures with anti-epileptics, and always find out the underlying cause and treat that cause also, not just by giving anti-epileptics. Now, although it's easy to say, but it is very difficult to diagnose neonatal seizures, especially if we do not have a EEG. So if we do not have EEG, we can falsely label 80% of the normal movements as seizures. And if we just depend on our clinical assessment, we may actually pick only 10% of the seizures. So if we are not having EEG, just on the clinical estimate, true positive cases will be only 9 to 10%, and false positive cases will be around 80%. So it is always important that apart from the clinical examination or clinical seizure, you should have an EEG in place. Now, my objectives of this talk is to tell about the definition, the recent classification of neonatal seizures, the common etiologies which we see in our day-to-day neonatal care, and the management protocol, anti-seizure medications, and the specific treatment. Now, it is clinically we define seizures as any paroxysmal alteration in neurological function, which may be either behavior, motor, or autonomic. Sensory phenomena is very difficult in neonates because they do not commute or they do not speak to us and they cannot describe the abnormal sensations. And more recently, seizures are defined on the basis of EEG. And on basis of EEG, they are defined as abnormal EEG patterns, which evolves, that is, changes location or morphology, should have at least voltage of 2 microvolts amplitude and should at least last for 10 seconds before we label that event as seizure. Now, until recently, we had classified seizures based on the clinical manifestation, that is either tonic, which leads to constant tonic posturing, or clonic, that is the abnormal movements. But recently, there has been a shift in the change of the classification. We now label the seizures as clinical, that is, where there is a clinical manifestation in the form of myoclonic, tonic, or clonic seizures. Then we have electroclinical seizures, that is the seizures where there is both a clinical component, that is, we see it as a seizure. And then when we do EEG, that it shows that yes, it is a seizure, and an abnormal EEG along with the clinical is called as electroclinical seizures. And the third and last but not the least is electrographic only. That is, any baby who is at high risk of seizures or is encephalopathic, he is put on EEG monitoring, and that EEG picks up the seizure, although clinically that baby does not throw up seizure in the form of tonic posturing, clonic movements, or myoclonic movements. That is called as electrographic only seizures. And let me remind you all that electrographic seizures are the most common neonatal seizures. Almost 80% of the neonatal seizures are electrographic seizures only. That means if we do not do or suspect seizures in such babies and monitor them on either on video EEG or conventional EEG or amplitude integrated EEG, we are going to miss them because there is no clinical manifestation of such seizures. So this was a previous classification which we talked about, that is subtle, clonic, myoclonic, tonic, depending on the clinical manifestation. It is no longer used now. And as you can see that different forms of seizures have different clinical EEG correlation. That is, tonic seizures has almost negligible correlation with EEG, and subtle seizures, which are the most, which were used to be the most common neonatal seizures, 50% of them have an abnormal EEG. So now the classification identification is predominantly based on EEG rather than waiting for the clinical manifestations to happen. So again, this was one of the babies was in the NICU and he had this abnormal body movements. You can see that he's having uprolling, twitching of the face, and both the arms are involved. When we did an EEG, the EEG was typical of seizures, and this baby was then started on antiepileptics. This is another. This is not a seizure. This baby had a bind, and this is he had a dystonia and abnormal posturing. This was an outborn who had a history of delayed cry, and he was having seizures in the form of abnormal tone and tonic-clonic cycling or paddling movements, what we call commonly, and his EEG was also abnormal, and this is a real seizure. Now, the incidence of the seizures happen maximally in the neonatal period, especially in the first 1 week of life. But the good thing about neonatal seizures is that the prognosis is good, and majority of them have a favorable prognosis. The incidence ranges from 10 to 20%, and more premature the baby, more risk he's of having seizures. So the risk of having a seizure is more in preterms rather than in term babies. And this number is not the accurate prediction because majority of them are underdiagnosed, and majority of the units still, especially in country like ours, do not have EEG, and majority are diagnosed based on the clinical manifestation as of now. So the commonest etiology of seizures is asphyxia, followed by perineal stroke or IVH. Then the third is common metabolic disorders like hypoglycemia, hypocalcemia, and fourth is infections, meningitis, which may be either bacterial, fungal, viral. So these three, four disorders form 90% of the causes of the seizures. And based on the etiology, what we are suspecting, we should accordingly treat the babies. It is very important to know the etiology because if it is underlying metabolic condition, especially hypoglycemia or hypocalcemia, then in that case, you may correct either hypoglycemia or hypocalcemia. In that case, if the seizures are not recurrent or frequent, you may avoid giving antiepileptic drugs. These are the common reasons for seizures. In the first 24 hours, we see HI, subarachnoid hemorrhage, or sometimes as inadvertent local anesthetics if it is given in the scalp. One of the important signs for inadvertent local anesthetic given in the scalp is that whenever you examine pupil of such babies, they will be fixed dilated. So it is one of the clinical marker that the baby is having seizure because of the inadvertent administration of local anesthetic into his scalp. These babies do quite well and usually recover within 24 to 48 hours. In premature babies, in the first 3 days, the most common cause of seizure is IVH, especially if it is grade 3 or grade 4. Then, as we move to the second half of the first week of life, the commonest cause of seizure in our setting is meningitis and the electrolyte abnormalities like hypoglycemia, hypocalcemia. Now, as we said that it is not only important to diagnose the underlying condition which causes the seizure because there is some insult happening inside the brain or the body, but also the seizures need to be controlled because seizures in themselves can cause hypoglycemia. They increase oxygen demand, leading to hypoxia. Whenever a baby is having seizure, his cerebral blood flow increases. He can have IVH, especially a premature baby. There is lactic acidosis, which can decrease the uh, ventricular function, leading to shock, hypoxia, low BP, acidosis. And if the seizures are persistent, that is, a baby is having status, he can have severe lactic acidosis, shock, and even death. So the studies have shown that any seizure which lasts more than 12 minutes per hour, they are associated with poor outcome, irrespective of the cause of the seizures. So our first should to pick up the seizures, and once we are sure that it is a seizure, then we should treat it promptly as soon as possible. Now coming to the approach, as with any other disease, the diagnosis begins with a good history. That is, we should have a detailed antenatal history of the maternal conditions like diabetes, any previous sibling death, what are the any resuscitation was given at birth, what was the weight of the baby, progression of labor, and similarly the onset of the seizures, whether it is a early onset that is within the 3 days or late onset, history of seizures in the family or similar history in the siblings, history of consanguinity is important. And then on examination, the first sign we should look is for the head size. Both micro and macrocephaly are important predictors of the prognosis as well as the cause of the seizures. Microcephaly, for example, can be seen in IUI infections, then macrocephaly can be seen in megalencephaly and other CNS malformations. Similarly, eye is an important organ to look for any chorioamnitis, cherry red spot, which are common in metabolic disorders. And then similarly, skin, we can have Ashley macules or any nevus formation because we know that both brain as well as the skin are ectodermal in origin, and problem in one can have be associated with problem of the other system. Similarly, massive hepatosplenomegaly is again a marker of IEM, and similarly, we should also look for peculiar order if we are thinking of IEM. IEM babies usually they are well for few days. As soon as they come to the feeds, they start deteriorating. You will get a typical history that baby was otherwise doing well, but after feeds, that baby they suddenly deteriorate in the form of shock, acidosis, seizures, and then we can similarly take the history. The investigations for every baby who every neonate who throws a seizure, the first investigation should be a blood sugar, which can be done at the bedside with the help of a glucometer. And any sugar which is less than 50 should be treated as hypoglycemia. Because remember, these glucometers were made for adults to diagnose hyperglycemia. So they are not very sensitive below 50 and above 500. So for a glucometer reading, you should consider a higher cutoff of 50. And if the sugars are less than 50, you should treat it as hypoglycemia. And the other electrolyte abnormality before you jump to the antiepileptic medications is should always look for calcium, either in the blood gas as ionized calcium, or you can send a calcium sample. If it is not readily available, then you can give at least a bolus of 2 ml per kg calcium, and then if the seizures continue, proceed to antiepileptics. All late onset seizures should have a CSF because meningitis is a common cause, and one third of the late onset sepsis have meningitis associated with them. Additionally, if there is no specific cause or if the seizures are recurrent, refractory to treatment requiring multiple antiepileptic drugs, MRI should always be done. So now there are various seizure mimickers which we should rule out before starting or before thinking of starting anti-seizure medications. And the commonest is the sometimes like we showed the GERD, where patients can have abnormal tone, dystonia, and these can be detected easily by clinical examination. The seizure episodes are usually the frequency is slow and they are more rhythmical movements, and they are rarely stimulus sensitive. They can be abolished if it is a jitteriness, which is again common in babies, even in normal babies for first 24 hours. So jitteriness is more rapid. It is can be controlled or can be restrained. It is stimulus sensitive. That is, if you stimulate or if you clap, the baby will jitter. But in seizures, they cannot be stimulated, they cannot be restrained, and majority of the seizures they are associated with autonomical conditions like tachycardia, hyperventilation, high BP. And remember, again, apnea is one of the close differentials of seizure. But in apnea, because of the seizure, majority of the babies will have tachycardia unless and until the seizures are persistent, when the baby can go into bradycardia. Otherwise, apnea, which is a manifestation of seizure, majority of those babies will have tachycardia rather than bradycardia, which is seen in apnea of prematurity. Now remember that we said that clinical diagnosis is not the accurate form or is not the actual form which we should rely on for diagnosing a seizure. The most accurate method is doing a video EEG. The benefits are worth the cost, and at least every unit should, at least level 3 unit should have this modality. And it also helps in the prognosis of the baby. So, according to the recent guidelines, video EEG remains the diagnostic choice for detection of EEG. If we do not have video EEG, at least we should do conventional EEGs. Last but not the least, if even if we do not have conventional EEGs, we can have amplitude integrated EEG. That is again now comes with multi-channel monitor and can be done even at the bedside. And it is, we do not need a pediatric neurologist. It is very simple to read and can be diagnosed at bedside. Many of the recent monitors, they have an algorithm which in themselves they will tell you that baby is having seizure or there are artifacts. Even now, in the absence of EEG, if you do not have an EEG, you can do an amplitude integrated EEG. So for those who do not have video EEG, there are different criterias or levels where you can start treatment based on the whether it is a definite seizure or a suspect seizure. A definite seizure is one where you have a seizure showing on a continuous EEG monitor. Yeah, there you should definitely treat those babies with antiepileptics. Now, if you have amplitude integrated EEG, which is showing a seizure, and there is a seizure in the form of either focal seizure, either in the form of focal clonic or tonic seizure, then again you should definitely treat those seizures. Now, if there is clinical seizures apart from focal, tonic, or clonic, but you're not sure, you can always wait. If it is happening recurrently, or you can later on do EEG, then only you should start with the treatment. Otherwise, please first rule out other conditions before jumping to antiepileptic drugs. So this is the algorithm. So all babies who are at risk of seizures For example, moderate to severe HI, a baby who's having encephalopathy, even if he's not actively throwing seizures, should be on EEG monitoring. And if EEG shows a seizure, you should definitely treat it. In the absence of EEG, all focal seizures, that is focal tonic or clonic, can be treated with antiepileptics, because focal seizures, either tonic or clonic, majority of the times they are seizures and they have an abnormal EEG correlate. But apart from those, if there are any non-specific movements, you can always wait and watch. Try to cuddle the baby, restrain the baby, and see whether they are responding or not. Then only if they are persistent, you do not have an EEG, and there are other markers or other underlying conditions for those babies to have seizures, then only you should start those babies on antiepileptics. Now, MRI should be done for babies who do not have a underlying identifiable cause. For example, definitely MRI is not required if baby is having hypocalcemia or simple meningitis. But in babies who have refractory seizures, recurrent seizures, uh, or has you are suspecting an underlying brain malformation in those babies, MRI remains the modality of the choice. As we have heard from the previous speaker, CT should be avoided in neonates because of the risk of radiation, and the yield is very good with the MRI. Now, in one of the studies, when all babies who had seizures, they were uh, MRI was done in those babies. 60 to 70% of the babies showed abnormality, and majority of them had white matter abnormality. So any seizure which is unexplained, refractory, recurrent should have an MRI. So this is the algorithm which is should be used for the seizures. Any baby having seizures, go by TABC, that is ensure proper temperature, maintenance of airway, breathing, circulation. Check the glucose first. Even if you do not have a glucometer, give a 2 ml per kg bolus of 10% dextrose, followed by 2 ml per kg of calcium gluconate. Even then, after these two medications, if the seizure continues, then still the drug of choice remains phenobarbital. Dose is 20 milligrams per kg. You can repeat the dose after 5 to 10 minutes if seizures are persistent. That is 10 mini bolus, then again a 10. So total of 40 milligrams per kg with a maintenance dose of 3 to 6 milligrams per kg per day in two divided doses. The second drug of choice is phenytoin. Phenytoin is second choice, although the efficacy is similar to phenobarbital, is because once we switch to oral form, the oral phenobarbital is better, bioavailability is better, it is better absorbed compared to the phenytoin. So although the efficacy of phenytoin and phenobarbital is similar, phenobarbital remains the drug of the choice, followed by phenytoin. Then even if the seizures are persistent, you can either choose levetiracetam followed by midazolam if seizures are still continuing. Many of the centers use levetiracetam as second line, which is fairly okay. So first line choice still remains the phenobarbital. Recent studies have shown that phenobarbital is definitely superior to levetiracetam, except for the babies who are having channelopathies, for example, KCNQ2, KCNQ3. These babies present with refractory seizures. In those babies, the first line choice remains phenytoin or carbamazepine. Now, there is an oral formulation of carbamazepine also available for pediatric and neonatal use. Except for these two conditions, the first drug of choice remains phenobarbital. The second choice can either be levetiracetam, phenytoin, or lidocaine. And the third line is midazolam, either as an infusion or a drug. In babies who have underlying cardiac condition, because phenytoin is a cardiotoxic drug, in those babies, the second line should be levetiracetam. Now, even sometimes, if we are suspecting an underlying IEM, or there is a history of intrauterine onset of seizures, which the history will be in the form of that the mother perceived increased fetal movements, which may be actually seizures. In those cases, you can give a pyridoxine trial, that is 100 milligrams of IV. You can repeat multiple doses to a total dose of 500 milligram. Or if the baby is stable, you can also give as 15 to 30 milligrams per kg per day in divided doses and repeat an EEG. If these are both diagnostic as well as therapeutic. Usually, if the baby is having pyridoxine deficiency, he has a dramatic response to the pyridoxine and the seizures abort. Similarly, there is a another drug which can be given in refractory seizures. Refractory seizures are seizures where you need two or more than two antiepileptic drugs. In those babies, you can always give a trial of pyridoxine and folinic acid. For folinic acid, the dose is 2.5 milligram twice a day, and you can increase it up to 8 milligrams per kg per day. So these are the doses of the common antiepileptic drugs which we use in our day-to-day neonatal care. And remember that phenobarbital is excreted by lung as well as kidney. So whenever a unit has associated kidney or liver dysfunction, you should always ensure that do not give more than 30 milligrams per kg of loading doses, because that can lead to increase the encephalopathy and can cause further injury. Other important thing with phenobarbital is it causes electroclinical dissociation. That is why EG is important, because once the baby has seizures, you are given phenobarbital. Although the clinical seizures have subsided, that is, there are no clinical manifestation of seizures, but he can still have seizures on EEG, that is electrographic seizures. And unless and until we do that, EEG will not be able to pick. So this is called as electroclinical seizures. This is called as electroclinical dissociation. That is, giving phenobarbital will sometimes cause cessation of the manifestations of the seizures, but there can still be underlying seizures which are continuing. So it is very important that to monitor the babies, to continue monitoring the babies with seizures on EEG, unless there is at least 24 hours interval of seizure free in EEG. Otherwise, you will not be able to completely abort the seizures. So carbamazepine, as we said, is the first choice in channelopathies. Dose is 10 milligrams per kg, and there is an oral formulation available. Phenytoin, as we said, that the oral absorption is erratic, so that's why we start with phenobarbital and continue with phenobarbital. Diazepam should be avoided in units because it has a lower therapeutic index. It has a short duration of action, and it uses sodium benzoate as preservative, which can increase the risk of kernicterus, especially if the baby has underlying history of jaundice. So diazepam should not be avoided. In refractory or status, we use midazolam infusion. It has got less respiratory depression and less sedation. Now, as we already said, that adequacy of treatment should be governed with the help of EEG, and we should abort both clinical as well as EEG seizures. That is, the child should have cessation of clinical manifestation, as well as EEG, which was previously abnormal, should turn to normal. That should be our goal of therapy, not just abortion of clinical seizures. Now, coming to the prognosis, as we said, majority of the common conditions have good prognosis. The best is with the late onset hypoglycemic and subarachnoid hemorrhage. That is it, almost 100% prognosis. And hypoglycemia, especially if the patient has seizure with hypoglycemia, remember that there is a 50% chances of that baby having an abnormal outcome. So this is something which is totally preventable. So all high risk babies should be monitored with hypoglycemia, and as soon as the sugars go below 50 on glucometer, you should start more frequent monitoring. Or now even dextrose gel is available in our country, and those babies can be started on dextrose gel to prevent severe hypoglycemia. So the take-home message is that neonatal seizures is a common problem. The commonest are subclinical seizures or EEG only seizures. So unless and until you have an EEG in place, you will miss at least 80% of the seizures. In fact, you will whatever we diagnose as seizures, 80% of those seizures will not be actually seizures, but common mimickers of seizures. Confirmation should always be done by EEG, and same is true for the treatment. Treatment goal should be abortion of both clinical seizures as well as abortion of the seizures on the EEG. Always pick up safe and effective antiepileptic. And whenever you are withdrawing the drug, you should always, phenobarbital is always the single drug which we keep it for the last, because oral formulation is easily available and absorption is best among all the antiepileptics. And now the recent evidence has shown that even if there is an acute symptomatic seizures or acute provoked seizures, once the baby is seizure free for 72 hours, you can taper the antiepileptic. So all symptomatic seizures, you can taper the antiepileptics within 72 hours or before few days before discharge. And the outcome for such babies and the babies who are continued on antiepileptics at 2 years of age was similar. Thank you, and I will be happy to take questions.
Excellent presentation, Dr. Akash. And as expected, your presentation had academic flavor and plus practical points. So we had best of both worlds. Uh, would wait for questions. In the meantime, I was just reading. Literature shows that all there is no correlation between subclinical electrographic seizures causing additional brain injury. So in such cases, whether to treat all subclinical electrographic seizures, what is your insight?
A very good and practical question, sir. If the seizures are the duration is more than 10 seconds, we should definitely treat them. But if they are more brief episodes lasting less than 10 seconds, then we can wait and watch.
Okay. And regarding tapering of anticonvulsants, you mentioned regarding the monosymptomatic seizures in which you can taper after 72 hours. How to taper anticonvulsant in other situations where you have started for other reasons?
If the It depends on the condition. If majority 80% of the seizures in units are acute symptomatic seizures, that is because of the underlying metabolic condition or some reversible condition. In those, as already discussed, that we can stop after 72 hours or before discharging the patient. Now, if there is some permanent cause, for example, malformation or grade 3, grade 4 IVH, in those babies, we should continue the antiepileptics for at least 3 months, monitor them with good clinical examination as well as the EEG. If either of them is abnormal, that is, the clinical examination is still abnormal, then we should continue the antiepileptics.
Right. There is a question in the chat box regarding HI babies with seizures in first 72 hours of life. How to taper anti-seizures medication?
Uh, 50% of the babies with HI, that is moderate to severe, will have seizures. So you should, if you are, if that is a seizure which has an abnormal EEG, you should treat phenobarbital being the first line of treatment. And now, if these babies' clinical examination is normal towards the discharge, also if his EEG is normal or MRI comes out to be normal, then these babies can be stopped on antiepileptics. However, if these babies are severe HI or there is some gross CNS insult, then these babies can be continued on antiepileptics, re-examined at 3 months of age with both clinical as well as EEG, and then decide. One point about HI babies is that if the baby is on therapeutic hypothermia, both during the cooling and the rewarming phase, these babies are prone to seizures. So you should continue antiepileptics during rewarming phases and do not taper it within the first 72 hours when the baby is on therapeutic hypothermia, because the chance of recurrence are very high on therapeutic hypothermia, especially during rewarming phase.
So how do you treat seizures during rewarming phase?
Uh, my point is that if you have already started treatment, do not taper it unless and until baby is off cooling for at least 24 hours. Even if baby is already on antiepileptics and he continues to have seizures on therapeutic hypothermia, uh, go on go on adding the second drug.
True. Right. Any other question? Now, regarding tapering of anticonvulsant when the baby is on multiple anticonvulsants, so what should be the duration and how do you taper it?
As we said that once, especially if it is a reversible cause or acute insult, once the baby is seizure for 48 to 72 hours, you can stop uh, additional antiepileptics. That is, if your baby is on two, stop one of them. Again, wait for 3 days, do a clinical examination. If you're not done EEG, do an EEG. If both are normal, then taper and stop. Last, phenobarbital remains the last drug because, as we already discussed, Oral formulation is easily available, and the oral absorption is best, almost similar to the IV form.
So although there are no guidelines, but many people need to taper by 20% of the dose.
We don't need to now. In fact, the recent guidelines which were published recently this year, they have shown that you do not need to taper. You can directly stop the drugs, even if the EEG is normal, but clinical examination is normal and it is an acute insult. They have compared outcome for babies who were continued on anti-epileptics versus babies where they stopped anti-epileptics before discharge. At 2 years, there was no difference either in brain injury, that is morbidity, as well as mortality.
Okay, thank you. Use oral phenobarbital for long term. There is a question.
Pardon, sir. Repeat, please.
There is a chat question in the chat box. Do we use phenobarbital for long? Uh,
Yes, phenobarbital, although there are some animal studies which shows that it increases the apoptosis, but as of now, we do not have any better alternative compared to phenobarbital.
Okay, and there's another one, Dr. How to suspect pyridoxine dependent seizures?
As we said, that pyridoxine seizures can have intrauterine onset. So always ask for increased fetal movement during the intrauterine life. Second thing is these seizures are usually refractory. They will require more than two antiepileptics. And once you are sitting on two or more antiepileptics, it's always better to give a trial of pyridoxine. And third, if you have an EEG, they have a typical pattern on EEG, which is characteristics of these seizures.
Right. Now, what is your second of anticonvulsant in units, Dr. Akash?
We start with phenobarbital. Second line is levetiracetam.
Because now people have moved from phenytoin.
Yes,
Most
sir.
of the units they have. Yeah, there are no more questions in chat box. Would request SN Singh sir for his comments.
Yeah, I think most of the controversial point has been asked and very well addressed by Akash. I am audible.
Yes, sir, you're audible.
Yeah. So he very well covered this, and there is still there is not enough evidence to recommend like whether to treat all subclinical seizures, because subclinical seizures follow 2 years follow-up has shown that almost similar outcome whether you give little longer anticonvulsant or no anticonvulsant, because anticonvulsant itself, which is phenobarbital, which is most commonly used as a maintenance, itself has a neurotoxicity. That is one controversial point. About Levra, for acute control of seizure, phenobarb is superior, has been proven. But for maintenance, Levra is less neurotoxic. So that's why even as a second line, the people are to Levra. And even for maintenance, there is a evidence that it is less toxic. So it's an individual choice if you want to give convulsion for certain time, especially those who persistent EEG abnormalities and neurological poor neurological signs, something is abnormal. So you can decide to continue for a little longer. So this may be the better choice.
Right. Just to extend the discussion, sir.
Yeah.
Babies follow-up cases of HIE who continue to have seizures.
Yeah.
In those cases, what is the ideal anticonvulsant on which we can discharge the babies?
Yeah. So yeah, basically, if the patient is, because in HIE cases, most of the times, usually the seizure burst out in 1 week. Some patient may have a very high risk of seizure or actually have a recurrent seizures. So if you decided to continue, till current recommendation, it is phenobarbital which continue. It has been proven that phenobarb is definitely promotes apoptosis. So that is neurotoxic. And Levra is less neuro and may be considered, but prospective trials are needed for this.
Any role of carbamazepine, sir, in such cases, HIE follow-up?
Yeah, yeah, I don't have any much idea about, and even literature about this as a maintenance. I don't think so.
Right. Any other question from any of the attendees?
Carbamazepine we have used in few refractory neonates, although there are no safety data in units, but more majority of the centers have now started using carbamazepine, and now the evidence is building. This is especially true for babies who have refractory seizures, especially
Maybe channelopathy.
we had one baby who had refractory seizures. He was started on carbamazepine, he responded, and later on he turned out to be one of the channelopathies. And now his oral formulation is syrup is also available, which was previously an issue.
Thank you, Dr. Akash. Excellent presentation. All three were very well presented. And as I said, your presentation especially had both the academic flavor and the practical points for all of us. Thank you so much. Thank you. Sakshi.
Thank you, Niranjan sir, and thank you, SN Singh sir, TR
Thank you
Yadav
so
sir.
much. So there's one more question by Prakash Manikot. He wants to understand how do you treat decerebrate and decorticate posturing?
Again, it depends on the underlying cause and is in the lecture in itself. So we'll discuss this in subsequent classes.
Thank you so much to all the chairpersons, our esteemed chairpersons, and the speakers. And I sincerely apologize for the time being extended as it was anticipated. We have extended, so we'll take care of the time management from our next presentations. Thank you so much to all the speakers and esteemed chairpersons for the valuable insights. Thank you so much, sir.
And
Thank you.
apart from all the chairpersons, faculty members, thank you, Sakshi. She's herself a speech therapist, and thank you so much for handling and being the backbone of this today's CME. Thank
Thank
you,
you,
sir.
sir.
Thank you.
Thank you to everyone.
Thank you, sir.